Before you do a head and neck assessment, you'll want to provide privacy, wash your hands, and explain to the patient what you'll be doing. We are first going to inspect the head, and we are looking at the skin color. It's nice and pink. We're also going to make sure that the head is the same size as how it should be for the body, and it is. And we're looking for any abnormal movements or twitching of the face that he can't control that are involuntary. We don't see anything. And we're making sure that the face is symmetrical. There's no drooping on one side, like in this picture. There's drooping on one side of the face, and this can be seen in Bell's palsy or in stroke. And we're also just looking at the eyes and the ears. Are they at the same level? And while we're here, we're going to go ahead and look at the facial expressions and test cranial nerve 7, which is the facial nerve. So can you close your eyes tightly for me and open them up? Okay, now smile for me, frown, and puff out your cheeks. Okay, and he did that with ease, so that cranial nerve is intact. Next, what we're gonna do is we're gonna palpate the head, the cranium. We're gonna check for any masses, indentations, look for skin breakdown, any infestations. And for this part, I like to wear gloves. So let's look at the hair. So what we're doing is we're feeling for any masses, indentations, and also with this, we're looking for any skin breakdown. And if your patient's immobile, you really wanna check the back of the head back here because they're laying on it a lot and there can be breakdown back there. What we're gonna do is we're gonna find the temporal artery and we're gonna palpate them bilaterally, and they are both found right here. And his are about a 2+. While we're here, we're gonna go ahead and feel the temporomandibular joint, and we're gonna feel right here, and I'm gonna have you open and close your mouth, and I'm feeling for any grating or clicking sensations, and I feel none. Moving on to the neck. So what we're going to do is we're going to inspect the neck first. So you're going to have the patient extend the neck up a little bit, and you're looking at that trachea. Is it midline? Look for any lesions and look for any lumps, like what you might see in thyroid problems like a goiter. And we don't see any of that. Then what we're going to do is we're going to test cranial nerve 11, which is the accessory nerve. So Ben, what I'm going to have you do is move your head side to side, up and down, okay, and then shrug, try to shrug against my resistance. And he does that with ease, so that nerve is intact. Then we're gonna place him at a 45-degree angle, and we're gonna have him turn his head to the side. And what we're looking at is the jugular vein. We're looking for any jugular vein distension, JVD. So Ben, I'm gonna just turn your head to the side like that, and we're looking for any distension of the vein, and we do not see any. Next, what we're gonna do is we're gonna palpate. So we're gonna palpate that trachea just to confirm it is midline. And Ben, do you feel any tenderness or anything like that? Ask him if he feels any tenderness. And I don't feel any lumps.
Now going to demonstrate the thyroid exam. The key to the thyroid exam is knowing the anatomy. So if you follow along with me and put your finger on the tip of your chin, on the mentalis muscle, and then slide your finger down the midline, the first hard structure you hit will be the thyroid cartilage, or the Adam's apple. You're actually going over the hyoid bone, but you generally don't feel it very clearly in the midline. So the first thing you hit is the top of the thyroid cartilage. Slide your finger down the edge of the thyroid cartilage like the prow of a ship, and you will next hit the cricoid cartilage, and this is the cricothyroid membrane. And then below the cricoid cartilage will be the first 2 rings of the trachea. It's important to know this anatomy because the thyroid gland does not really lie anywhere near the thyroid cartilage despite the name. The exam is best done by getting behind the patient and once again using my anatomy, finding the thyroid cartilage, the cricoid cartilage, the first 2 rings of the trachea. I then put my fingers in the midline over the first 2 rings of the trachea. That's where the isthmus of the thyroid lies. I then flatten my fingers. It's almost as though I'm trying to choke the patient. And I slide my finger slightly to the side, and now I ask the patient to swallow. And I'm concentrating on whether one set of fingers went up disproportionately compared to the other. Once I've done that a couple of times, I can then push the thyroid gland over with one hand and palpate the lobes with the other hand, and then do the same thing this way.
examination may reveal an auscultable bruit and a palpable thrill.
Then next what we're going to do is we're going to palpate the lymph nodes, all sites of those. And Ben, as I do this, tell me if you feel any tenderness. And what I'm feeling for is any hard lumps or anything that may be inflamed. So what we're going to do, turn a little bit this way. And here we go. We're going to start at the pre-auricular, which is right in front of the ears. Then we're going to go to the back of the ears, the post-auricular. Then we're going to go to the occipital, the parotid, jugulo-digastric. Then we're going to go to the submandibular, and then the submental. Then we're going to go to the superficial cervical, and then we're going to make our way down to the deep cervical chain. Any tenderness so far? Then we're going to go to the posterior cervical, and then right above the clavicle, we're going to go to the supraclavicular. And did not feel anything and no tenderness.